Good evening, ladies and gentlemen. We welcome you to the expert webinar series organized by the Ceylon College of Physicians in collaboration with the Sri Lankan Association for Geriatric Medicine. I'm Dr. Shahan Silva. I am the secretary of the Sri Lankan Association of Geriatric Medicine, and I'm also council member of the College of Physicians. And myself, along with Professor Sarath Lekamasan, who's the president of Geriatric Medicine Association, first of all, take the privilege of thanking the Ceylon College of Physicians for giving the opportunity for our association to work in collaboration, in dedication this month of November for learning opportunities in the field of geriatrics. And we have with us today an eminent speaker from our neighboring region, from Malaysia. We have the privilege of welcoming Professor Tan Maupin, professor in geriatrics. She holds many accolades, and she is a person who is a stalwart in the field of geriatrics in this region. Among her accolades, she is the medical director of managed care, the honorary general secretary of the College of Physicians of Malaysia, the honorary secretary of the Malaysian Society of Geriatric Medicine. She is also an adjunct professor of the Sunway University and also an editor of PLOS ONE and Frontiers of Medicine. And we are indeed privileged to have her talking to us about falls in Asia in terms of cultural aspects. Over to you, Professor Tan. We would like to also give some housekeeping announcement. Please keep your mics muted during this session. You may pose in your questions through the chat box, and we will entertain them at the end of the talk. Thank you, Professor Pin.
Thank you. Thank you very much. I hope you can hear me.
Yes, we can. We can.
Oh, good. Yeah. Thank you so much. It's a pleasure to be able to share some of the things that we've been doing in Malaysia. And I look forward to our societies linking more in the future. Yeah. So basically, I've been in Malaysia I've been working only in Malaysia for 10 years. I spent much of my life studying and working in the UK, and I'd like to basically share some of the work that we've done in Malaysia over the last 10 years on falls, and basically present falls in a Asian cultural context again. So here we go. We'll see how it goes. So first of all, I'd like to just introduce you to some work done by a PhD student of mine. He's graduated now, Dr. Muhammad, who actually is an occupational therapist. And he actually looked at some of the work he's actually basically did a scoping review of the sum total work that's ever been done on falls in Southeast Asia. Of course, Sri Lanka is slightly outside Southeast Asia, but we don't actually have an equivalent publication for the body of work for Asia. So I've only got Southeast Asia. So when he looked at the available studies, this was back in 2016 or so, we didn't find many. So we were able to actually do a publication on all the work ever published in falls in Southeast Asia, and we found 30 papers. So not many at all. This is the intervention studies that have ever been conducted. Not all of these were published at the time of his work, but they have all, of course, been published now. And at that time, there were only 6 intervention studies in the whole of Southeast Asia. Nearly all of them looked at exercise, but the study that I did with a group of us in Malaysia was actually a multifactorial assessment, multifactorial intervention. So this was what the summary that he came up with. Basically, he found that while most of the risk factors identified for falls in Asia, were considered risk factors from international studies, unique risk factors to the region include traditional housing, ethnic groups, meal frequency, eating bought meals rather than home cooking. So if you buy food rather than cook, that's a very Asian thing. In other parts of the world, if you don't cook, you don't eat. Living alone, and lack of consistent electrical supply, those are actually risk factors for falls in Southeast Asia that's been published. They didn't find that the home environment contributed much to the risk of falling, but of course, there were very few papers on this. And then they had not actually looked at the interaction of the older adult with the environment. So there's single intervention, cataract surgery, and multifaceted interventions had been evaluated, as well as exercise as a single intervention, while those were the 6 registered physical and multifaceted interventions, but they're not actually available. Okay, so 5 of the 11 ASEAN nations, Southeast Asian nations at that time, did not actually have any published studies on falls. So falls in our region, especially, is actually still very little researched in essence. So let's look a little bit about the prevalence of falls. So this is actually some of the ethnic differences that we've looked at when it comes to falls prevention. So of course, many of the research studies that have actually evaluated falls prevalence have been in Caucasian populations, and also we have papers that's been published from East Asia, but they've been from very homogeneous population, mostly involving either the Japanese population, the Korean population, the Taiwanese population, and of course there's a fair few publications from China nowadays. But very few studies internationally have looked at ethnic differences in falls risks. So what we have actually managed to do is to actually collect data from 1,500 people over the age of 55 living in the Klang Valley of Malaysia. And we stratified our recruitment using the electoral roll sampling. We stratified it so that we had equal numbers of the ethnic Indians, ethnic Chinese, and ethnic Malays. So those are the 3 major ethnicities in Malaysia. So that actually makes us a very unique country, that everything we do, we can actually do 3 ethnic comparisons for the 3 major ethnic groups, not just in Asia, but also around the world. And this is what we found. Okay, so when we looked at when we broke them into 5-year age, because we have quite a large number, so we could afford to look at 5-year age groups. Of course, as they got older, the prevalence of falls increased. Overall, that's the blue vertical bars. And by the time you are over the age of 75, you had a 1 in 3 chance of having had at least 1 fall in the past year. But when we look at the ethnic differences, I'm not sure how people in Sri Lanka feels about being called ethnic Indians, but most of our ethnic Indians are actually Tamil speakers. And basically what we found was that the ethnic Indians in our country, mainly Tamil speaking, actually had, because they originated mainly from Tamil Nadu, mainly had a higher risk of falls compared to the other 2 ethnicities, with the ethnic Malays, the orange bars, being the group that are least likely to fall. So for the ethnic Malays, the risk of falls, even when they reach 75, is 1 in 4, whereas the ethnic Indians is actually getting to less than 1 in 3. It's about 40%. So regardless, this shows that falls are common, even in Asian ethnic groups. But overall, the falls prevalence is actually lower than that has been reported in Caucasian populations, which say that if you're over the age of 1 in 3, I'm sorry, when you're over the age of 65, 1 in 3 people are actually at risk of falls. So we tend to present our statistics like this. If you are over the age of 55, you have a 1 in 5 chance of falling over the past year. If you're over the age of 65, it's a 1 in 4 chances. And then if you're over the age of 75, it's 1 in 3. And this is very useful in the clinical setting, because when patients come up with you with a fall, you can reassure them that they are actually not really that much of a minority when it comes to in comparison with other people their age. But falls do have negative consequences. And we feel that the negative consequences are even bigger when it comes to the Asian context, particularly specifically the Malaysian context. So what we're seeing is this is actually 10-year follow-up data from a study that started in 2002, where my Professor Philip Poi actually collected data from 200 fallers who attended to the emergency department, and he called them up 6 months later to look at their function. And this was what he found by 6 months after an index fall, presenting to the emergency department in Kuala Lumpur. People actually had an increased level of disability. So this is a Bartel index, and overall, more people actually develop dependency in these domains of the Bartel index, which are basic activities of daily living. So more people had difficulty climbing stairs, bathing, walking, going to the toilet, and also increased incontinence levels. And this was what shocked us. We were actually able to get 10-year mortality data through our National Registry Department. And within 1 year of one index fall to the emergency department, 20% were no longer alive. And by 10 years, only 20% were still alive. Now, cancer statistics look a lot better than this nowadays. And really, it doesn't really matter whether you have a hip fracture or not. It seems like if you come into the emergency department with a fall, you have a 1 in 5 chance of not actually being alive in 12 months. So with that under our belt, we were actually able to apply for funding to actually conduct a randomized controlled trial looking at multifactorial multifactorial interventions for falls prevention. And so we recruited people over the age of 65 with 2 falls in the past 12 months or 1 injurious fall, and we randomized them to individually tailored exercise intervention, which comprise 6 components: Otago exercises, home hazards assessment, cardiovascular assessment, visual assessment, medications review, and also falls education. And then the control arm actually were just carried on having conventional treatment, but so that they didn't feel they had nothing, they actually had a bit of health advice. And then we followed them up over 12 months with a fall diary. And then we also did an assessment, a clinical assessment at 12 months if they were able to come. The attrition rate was very high, so the diary exercise was more useful. So, but in the meantime, while the endpoint was cooking, we were actually able to do some cross-sectional evaluation by actually also getting a control group with no fall over the past 12 months, and doing direct comparisons with our fall lists. And this is what we found. We have actually a very high polypharmacy rate. And so we were able to look a lot at medications. And we found that when we looked at antihypertensives and falls, which, you know, a lot of times our doctors just stop the antihypertensives as soon as the older person falls. I don't know if people in Sri Lanka do the same, but Malaysian doctors tend to do that. And that really scared me. I was like, but they might have hypertension and that still need treating. And so what we found was we looked at just hypertensives. There was no relationship between hypertension and falls, hypertensives and falls. So even if they were taking 2 or more antihypertensives, we look at any hypertensive at all, or if we look at individual antihypertensive classes. And then after that, we decided to look at this group of medications called FRITs. FRITs are false risks increasing medications. So I think we all know what they are. They are vasoactive drugs, antiparkinsonian, antipsychotics, benzodiazepines. Those are FRITs. And when we looked at polypharmacy, as per se, so if people were just on 5 or more medications, there was no significant increased risk of falls. But if they were on 2 or more falls risk increasing drugs, then there was a significant increased risk of falls. So these are what we call forest plots, and the square boxes or the triangles are actually the odds ratios. So an odds ratio of more than 1 would suggest there's an increased risks, but it's only statistically significant if the 95% confidence intervals do not cross 1 or exceed 1. Okay, so as you can see, having 2 or more FRITs is actually significantly associated with increased risk of falls, while polypharmacy is not. And if we totally exclude FRITs, even the odds ratio approximates to 1. So we decided to also look at this rather new thing called anticholinergic cognitive burden. So this is actually a scale, the ACB scale, and anticholinergic drugs, I believe we all know, are actually drugs such as chlorpromazine, which are antipsychotics. Benzodiazepine also have anticholinergic properties. There are a group of drugs that we call anticholinergics, which are actually used for the anticholinergic properties to treat the unstable bladder. So those are oxybutynin, trospium, tolterodine. Those have very strong anticholinergic effects. But with the anticholinergic cognitive burden, it also identifies medications with mild or possible anticholinergic effects, which it gives a score of 1, whereas a medication such as chlorpromazine would have a ACB score of 3. And then you would actually add up all the scores and you get a total anticholinergic burden score. And this anticholinergic drugs actually seem to be associated with increased risk of falls. So amongst our fallers, we actually found that they were significantly more likely to be on any medications with anticholinergic properties, even mild anticholinergic properties. So these were the drugs with anticholinergic properties that we identified from our study. Drugs like atenolol, it's a beta blocker, ACE inhibitor, colchicine, dipyridamole. I'm sure you use those drugs a lot too. And those actually seem to have a very mild or possible anticholinergic properties. Whereas when we looked at the ones with really significant anticholinergic properties with a score of 3, there were not that many. So doctors by and large were very careful of actually prescribing drugs with very strong anticholinergic properties. But when we looked at drugs with mild anticholinergic properties, out of our 260, out of our 428 cases and controls, 112 drugs with mild anticholinergic properties were identified. So this is statistics, again, significantly higher likelihood of actually consuming any medication with anticholinergic property. So 28% in those with fallers compared to only 18% in non-fallers. We also looked at inappropriate prescriptions using the stop-start criteria. With the stop-start criteria, we found that 59% of our fallers were on at least one inappropriate prescription compared to 37% of our non-fallers. And the further up we go, so with greater than 3 inappropriate drugs, you see a lot more fallers as well. So this is evidence that inappropriate prescription is also associated with falls in older adults. So we had a lot of fun with medications. We also had looked at orthostatic hypotension. Now, for a very long time, we've always publicized orthostatic hypotension as something that is associated with falls. But when we looked at our fallers, 25.7% actually fulfilled the criteria for orthostatic hypotension, but 17.9% of our non-fallers fulfilled the criteria for orthostatic hypotension. And this level of significance is actually not below 0.05, which means it's not statistically significant. Now, this doesn't mean that orthostatic hypotension is not associated with falls. There is something wrong with the definition. In fact, the 20 systolic and 10 diastolic difference actually is too low. It's too blunt. Basically, we are actually catching a lot of people with no symptoms. We call it asymptomatic orthostatic hypotension. And therefore, we need to revisit the definitions of orthostatic hypotension. Basically, what we actually found, however, if we looked at the systolic blood pressure standing, we actually could, at 1 minute, we couldn't establish a difference between fallers and non-fallers, but by 3 minutes, there was a highly significant difference in blood pressure standing between fallers and non-fallers. So perhaps what we should actually be doing is measuring standing blood pressure at 3 minutes with fallers. But we haven't quite decided what's the cutoff. So there's still quite a lot of work to be done. Okay, so this is actually Izati's work. Izati is now an associate professor with us. I'm so proud because she was my student, and so she started off as a master's in internal medicine student, and she actually used a beat-to-beat blood pressure measurement. So with the current orthostatic hypotension definition cutoffs, it is extremely blunt because nearly everyone fulfilled the 2010 criteria. So she looked at changing the diagnostic criteria, and what we found as the most useful criteria was to just ignore diastolic blood pressure drop altogether and just look at systolic blood pressure change, and using 30 millimeter mercury systolic drop was perhaps the most sensitive, effective way of actually diagnosing orthostatic hypotension. So we are hoping that more and more work will be done with this, and we will hopefully come up with more useful definitions of orthostatic hypotension in the future. Okay, so this is her work showing that if we use a 30 cutoff, 40% of fallers would actually have a 30 millimeter systolic cutoff compared to only 8% of non-fallers, which actually gives us a specificity of 92% and a sensitivity of 40%, which is actually much better than 2010, because when we use continuous measures, nearly all of our fallers fulfilled it, but over 50% of our non-fallers fulfilled the cutoff. So there are a lot of issues current with our definitions for orthostatic hypotension. We also looked at osteoarthritis. For so long we've been teaching osteoarthritis is a risk factor of falls, but when we looked at our participants who have been diagnosed with a self-report by a doctor with osteoarthritis, 1 in 3 fallers had osteoarthritis diagnosed by a doctor, but 1 in 3 non-fallers had it too, so there was no statistical significance. We also examined them clinically, and again, 1 in 3 of them actually had osteoarthritis clinically as well, so there was really no statistical significance when it comes to clinical osteoarthritis in our fallers. When we look at their radiological findings, about 80% of all our participants had osteoarthritis on their knee X-rays, and there was really no statistical significance. So this actually throws out the concept that actually osteoarthritis is associated with falls. But that's not the end of the story. So we decided to measure the severity of osteoarthritis, and this is why there is a discrepancy in what we're finding with what's actually happening on the ground. So the reason why osteoarthritis is still a risk factor for fall is because when we look at clinical OA, we measured the severity of the symptoms using a scale called the WOMAC scale. We found that people with severe clinical osteoarthritis were significantly more likely to fall than those with mild osteoarthritis. So this is what we call an logistic regression analysis using dummy variables. So what we do is we find a reference coordinate, a reference value, which here is actually mild osteoarthritis, and we compare it to moderate and severe osteoarthritis diagnosed clinically. And severe osteoarthritis was significantly more likely to have falls than mild osteoarthritis. When we look at radiological osteoarthritis, a rather interesting picture occurred. So now people, because 80% of our participants actually had radiological changes consistent with osteoarthritis, we actually had this group with no symptoms. So compared to those with presence of radiological changes but no symptoms, people with mild osteoarthritis were significantly less mild osteoarthritis on X-ray were actually those people with X-ray changes but mild symptoms of osteoarthritis were significantly less likely to fall than those with X-ray changes and no symptoms. So we actually postulate that having a bit of osteoarthritis is actually protective from falls. And we actually did a bit more analysis that actually shows that anxiety explained this relationship, whereas depression explained the relationship with increased risk of falls and severe clinical osteoarthritis. So we had a lot of play. We were able to play with a lot of the risk factors when it came to by just looking at a case control study involving just under 500 participants. And not to keep you in any more suspense, here's the results of my fate. So remember, we actually randomized to individually tailored versus conventional treatments. And we had 6 components and followed up with the diary. So using an intention to treat analysis, I'll just move on a bit. So these were the assessments that we did. Okay. And this was a cardiovascular assessment. So we actually did carotid sinus massage, as well as head-up tilt table tests. Okay, and these are the physiological changes that would actually make us diagnose vasovagal syncope. I'll go back, and this is carotid sinus hypersensitivity. So actual heart rate stopping after you've actually done carotid sinus massage. Okay, and false education. And this is the diary that we used. We actually had a lot of participants who couldn't read or write. So we had a smiley faces for no falls, and actually a cartoon of falls for falls. And they just kind of made a mark when they fell. So the notes was if they were able to write, if not, it was okay to leave them blank. And as always, we always look at baseline characteristics, so we don't do any hypothesis testing, because by the fact that they're randomized means that any differences would have occurred at random. And these were the risk factors identified. So drugs was the most prominent risk factors, and fear of falling was also quite a prominent risk factor. Gait and balance abnormalities only in 2 out of 3 of our fallers, compared to 90% of fallers in other settings. Basically, my fate's outcomes, when we looked at rate of falls, fall recurrence, mortality, time to first falls, all not statistically significant. when we looked at the inverted Kaplan-Meier plot. So this is actually further up you go, is the more likely you fall, and there was no significant difference between falls outcomes for intervention and control. We were a little bit disappointed, but we were not surprised because it was really difficult to do all those 6 components in 1 year. It was all got, some things got done at 9 months. So we weren't able to actually establish a difference after 1 year. So perhaps it's not really an effective approach in our setting, but we wouldn't actually not advocate the use of multifactorial assessments. And in fact, we did find significant improvements in physical measurements. So this is a timed up and go. So we got them to walk 3 meters, turn around and sit back and walk back again and sit back down on a chair. And that test time improved. Functional reach is how far they can lean forward, stretch forward without losing balance. And that also improved in our intervention group with the Otago exercises. And the grip strength stayed the same, but in a control group, the grip strength deteriorated. So this is actually evidence that actually Otago exercise does seem to do something if it doesn't seem to reduce the risk of falls. And we were also able to look at the OA subgroup, and we found that people with OA were able to do Otago exercises, and they also had, we used a machine called the Balance Master, and we're able to look at the limits of stability and postural sway, and the limits of stability was much better with intervention with the Otago exercises compared to controls. Okay, so we also looked at false reporting, and this is very helpful for developing country contexts. So traditionally, a lot of papers keep saying that retrospective reporting not accurate, and so everything had to actually have to be done with a very expensive and very labor intensive diary exercise. So we did do the diary exercise with my weight, and yes, it was worthwhile because what happened was we missed a bit of we had a bit of underreporting when we didn't do the diary exercise. We actually asked them to do a retrospective recall, and there was also quite a bit of over-reporting, and the agreement wasn't too good. It was only moderate agreement. But it also shows that retrospective reporting is still useful because there is still moderate agreement. But when we came to our longitudinal cohort study, we also did a diary exercise. We found that for population-based studies, cohort studies, diary exercises are not useful because the return rate is very, very low. We sent out 200 diaries, we only got 31 back. And the agreement with retrospective recall was nearly perfect agreement. One being perfect agreement, our agreement was 0.89. So we now only use retrospective recall for our cohort study, but we will still persist with diary exercises for intervention studies. We also looked at some pooled data looking at risk factors for falls in Malaysia. So we actually used the Malore study, which is our longitudinal study of aging that we actually looked at the prevalence in, but we merged this with TOUR study, which is a larger cohort that was actually started in Malaysia at around the same time. And those 2 cohorts are now merged to become the ageless cohort. And when we looked at these 2 cohorts merged, we found that self-rated health, increased BMI, diabetes, arthritis, self-reported arthritis, that is, urinary incontinence, and reduced hand grip strength were prominent risk factors for falls in our culture. There is no gait and balance in here. So, and what was quite surprising to us was how prominent urinary incontinence was as a risk factor for falls, as well as diabetes. We also compared our study with some international studies. So this is a Malore study compared to the EPIC Norfolk and the Formosa. Formosa is actually a study from Nuremberg, Germany. And what we found was that compared to people from EPIC Norfolk and Nuremberg, we actually had slower gait speed. We walked at half the speed, and we had weaker grip strength. While we had a lower BMI, we had a higher percentage body fat. Okay, And when we looked at falls in these data sets, our data set had a lower prevalence of falls. People in Germany, older people in Germany seem to fall a lot. Body mass index, ours was lower, but when we look at fallers versus non-fallers, BMI was a significant risk factor, whereas when we looked at Norfolk, Epic Norfolk in the UK, not a significant risk factor. In Germany, still a significant risk factor. But when we look at percentage body fat for Malaysians, increased percentage body fat in people with falls, but no increase in Epic Norfolk, and in Germany, slight increase only. Okay, so this is a statistics. I won't go over that. So this is finally, I'd like to end with a systematic review that has looked at interventions in Asia. Okay, so what works when it comes to falls prevention in Asia? So this is actually meta-analysis looking at exercise A, in terms of number of fallers. This one is number of falls, B, and then number of fallers injured, that is C, and then D just looks at number of fallers for exercise using Tai Chi, and then E is number of falls exercise using Tai Chi, and then F is the multifactorial intervention in terms of looking at number of fallers. So number of fallers is how many people have fallen in the last 12 months, whereas number of falls is the total number of falls that they counted in all their fallers. Basically, when we looked at exercise, this is a forest plot again. So if everything falls to the left of the vertical line, it is actually favors the intervention. If things fall to the right of the vertical line, then it favors controls. And across the board, it also favors exercise intervention, and all the pooled data, all highly statistically significant, suggesting that exercise works in Asians and Tai Chi works in Asians. When it comes to intervention studies, we were only able to pool the results of 2 studies, and so far, multifactorial intervention, it doesn't seem to be reducing falls in Asia. It might be that the studies are too small, but it might also means that multifactorial intervention might not be the correct approach in the Asian setting. Okay, so I'd just like to show you a couple of pictures. This is the Falls and Syncope service in the UMMC, University of Malaya Medical Center. So if any of you ever come to Kuala Lumpur, please come and see us. And this is my setup. I actually have a tilt table test, and we do the assessment at the tilt room. And if they need physio and OT, they're just upstairs, and we send them upstairs to physio and OT. But they usually prefer to come back on another day because they're quite tired after spending an hour or 2 with us for their falls assessment. This is a position statement on falls and fragility fracture, open access, openly available. You're very welcome to download and use it. It's actually held in our Malaysian Society of Geriatric Medicine website. And this was the first World Congress on falls and postural stability, and that used to be our health minister. We've changed to health minister twice since, and that's Professor Tash Masood. He's actually just stopped being the president of the British Geriatric Society, and that's our president. That's our vice president now. He was the president of the the Malaysian Society of Geriatric Medicine then, Professor Philip Hoy. And we're very proud that we actually hosted the first World Congress on falls and postural stability in Kuala Lumpur in 2019. Okay, and we are now developing the World Falls Guidelines, and I'm part of the guidelines development group. I head the low and middle income countries group with a lady, Monica from Brazil, and also Fernando from Colombia. And ongoing research, we actually have a study that's looking at psychological effects of falls, as well as autonomic responses and the home environment. And we also have another study ongoing that's looking at obesity, sarcopenia, and falls using MRI and biomarkers. So, and this, all this work was only possible with a very huge team And so I can't actually list all the names. Some of them are actually only listed as groups, and these are our community partners who actually help contribute towards recruiting participants to our studies. And there's been a lot of grants that has actually helped fund this work. So thank you very much for the opportunity to share. I think I might have gone a bit over time, but I do get a bit excited when I'm given the opportunity to talk about some of our work on falls prevention in Kuala Lumpur. Thank you very much.
Thank you very much, Professor Tan, for that wonderful talk. We opened up a lot of thought in regarding falls. We need to have an outlook like that.
I'm very happy to take questions.
Just a question about, can you hear me? Hello?
Yes, yes,
yeah.
Yes.
You mentioned about the ethnicity and you spoke of the Indian, ethnic Indians. So I suppose our country is composed of a community which is similar to Indians with regards to genetics, etc. When you when you think about that community, what are the factors that you would say that they were at risk of developing falls when you analyze them in a subgroup?
We couldn't we have started off with 1,500, so we did manage to look at some statistics to see whether we could explain this difference, and no matter what we did, we couldn't explain these differences, so we don't know for sure. We do know that ethnic Indians have an increased risk of diabetes, but when we add diabetes into the equation, it didn't take away the statistical significance. So there might be genetics, there might but I presume lifestyle issues might play a strong part, the environment, etc. But we couldn't find anything because we collected a lot of data. We couldn't find anything that would explain the difference at the moment. So it's a very interesting area for further research.
And also you mentioned about postural hypertension.
Yes.
The targets being very minimal, because in fact, postural hypertension is an interest area of my study. So you would say that the targets needs to be more liberal, is it?
Yeah, the 2010, I think a lot of us find that people actually reach 2010 differences, and not all of them actually would have fallen because of the drop. Yeah, so what it really means, we don't know. But we do know that the bigger the drop, the more likely it is to be what's actually causing the falls. But if we actually just jump to, oh, okay, they've got significant OH, that's the cause of falls, that's very dangerous, because we might be missing some more serious, more sinister risks of falls, such as cardiac syncope. And of course, a lot of them have postural instability, isn't it? And, we should be actually addressing those instead of just the OH, orthostatic hypotension. And the reflex section is, of course, stop the antihypertensives. And that's I don't think a very good practice, because, if they have hypertension, they ought to have that treated, because I think the risk of strokes quite high as well at this age group.
Yes. Professor Lekhamasam, do you have any comments?
Yes. Just picking up that little discussion you had with Shehan about the ethnic differences, discrepancies of falls. Just wonder the role of vitamin D, because if you look at the skin color, the Chinese and the Malays are fairer than Indians, and then wonder whether the Indians have low vitamin D levels because of the skin color when you compare with the other two ethnic groups. Have you looked at the role of vitamin D and falls in these people?
Yeah, we did measure vitamin D, and it didn't seem to explain the difference. But we do know that, our ethnic Malays have very low vitamin D levels. They have lower vitamin D levels than the ethnic Indians, because they're all covered up.
All right.
Yes, so I think that might be the reason why it's not shown up as the factor, because even though the skin is darker in the Indians, the Malays don't expose themselves to sunlight whatsoever because they're all covered up.
Yeah. But what about the vitamin D, role of vitamin D as a treatment for people with falls? Is it
Yeah, that's a very interesting question. So nowadays we are very scared about vitamin D because the evidence is now showing that if we just indiscriminately, last time we used to actually just jab everyone with an vitamin D injection when they come to clinic. But we can't do that anymore because we know that indiscriminate prescription of a vitamin D actually increases falls. So we actually need to measure the vitamin D levels and only replace if it's low. And it's a huge problem in our setting. People have to pay for the vitamin D assays, and that's a lot more expensive than vitamin D replacement. So it's a real problem. I don't know if it's a problem in Sri Lanka too.
Definitely it is.
It is, yes.
So it's so cheap to just, vitamin D is cheap as chips, isn't it? You can just give it out like sweets. But to do a blood test is quite difficult because they can't afford it. Yeah. So what we tend to do is we cheat. Yeah, if they're ethnic Indians or Malays, we give it anyway because we know that most of them will be deficient. I don't know if that's what you're finding in your population as well. But there's no evidence base, but it's based on clinical kind of gut feeling.
Yeah.
Yeah, I'm sure you're doing that as well, isn't it? Because you know that your population are mostly vitamin D deficient, so you give it anyway. Yeah, and then for the ethnic Chinese, if they're housebound, they don't go out, we also give them vitamin D. But our ethnic Chinese tend to be a bit wealthier, so more of them can afford vitamin D assays.
Do you think the role of diet, as in dietary practice and cooking habits, play a role? Because there must be a striking difference between the practices of Indians and I suppose Malays and Chinese in one side and Indians on the other side. Do you think that that would also play a role?
Yeah, ethnic Indians, very high level of anemia, though we've not actually linked anemia with falls yet. We could do, but we haven't got around to it. So and it's a diet, isn't it? The ethnic Indians seem to have a very little iron in their diet, or they seem to eat a lot of chapati, and that has a kind of phytates, which actually chelates iron. So we have very high prevalence of anemia in our ethnic Indians, but we didn't actually adjust our falls rate for anemia, but my gut feeling is not going to take it away anyway. But the diet in our country is poor. I think we win for Asia when it comes to obesity in Malaysia. Very high fat, carbo rich diet in our population, and everybody buys food from the shop. Nobody cooks. Yeah. So very high salt levels as well. Yeah. And we do know that one of the things we do try and do is to encourage people to cook more at home. Yeah, we didn't look at shop bought food, but there's already evidence from other Asian sources that shop bought food actually is a risk of falls because of the poor nutritional contents. Do people in Sri Lanka cook?
They do, yes. Yeah.
Oh, right. So they cook at home. They don't buy outside food.
Yeah. Most of people, I think large majority, I would say they cook at home.
Okay, so that's not part of the Sri Lankan culture, but Malaysia's terrible. Hawker food is so cheap. A lot of people don't have a kitchen.
Okay.
Yeah. So it's so cheap. It's cheaper to buy than to cook for yourself because you got to buy the ingredients, you got to buy the stove and everything. But it's not, of course, not healthy.
Okay.
Is there a startling difference between the family support with regards to Indians and the Malays and the Chinese, or again in the other spectrum? For instance, now in our country we have a lot of caretakers and carers from the family coming to help the older adults. And people tend to live not alone. They live in houses where there are extended families. But is that pattern of concern in Malaysia? Is it different?
I think we're about the same. We have a lot of multi-generational households, and only 7% of our older adults live alone. That's quite small. I don't know whether it's lower than 7% in Sri Lanka. Living alone does seem to increase your risk of falls. But it is because so few of ours live alone, we weren't actually able to do much with the stats. And then with what we couldn't do was to separate family support with other social support. So there was no significant differences in levels of social support between the ethnic groups. Yeah, and as generally all our older people have very good social support. Yeah, which is something quite lucky, I guess, in our country because we haven't developed to a state where older people are lonely and living alone. Those sort of things. Yeah, I don't know whether we'll ever get there because house prices are so expensive. Children don't leave home nowadays anyway.
Rosalie Kamasam, do you have any comments? Any more comments?
Not more really, no.
In the absence of any other questions, we would like to extend our thanks again to Professor Tan for taking her time in a very difficult time when I suppose it's close about 11 o'clock in the evening, right?
No, it's not a difficult time at all. This is normally when I have my international meetings.
Yeah.
Yeah, I like it because then you don't have to make sure that your diary is free. It's like the diary is always free at this time. Yeah. So unless nowadays we're not going anywhere, isn't it? Yeah. So unless I had a social event, yeah. But we don't have social events. I don't think I've been out for dinner for many months or even a couple of years. That's terrible. Yeah.
Similar situation in our country as well. And we would like to invite you to be a part of our association in the future. We would like you to get involved in our activities, academic as well as in research. And also would like to invite you, if possible, as a speaker at next year's annual Congress in March. We'll be in touch with you.
Thank you so much. Thank you. Yeah, thanks so much for inviting me.
Yeah, it was a pleasure. So good evening to all of you, and we wish you a safe and bright future. Take care.
Same to you. Thank you.
Bye.
Good night now.
Okay, nice time.
Bye-bye.
Yeah,
Bye.
bye.
Bye.